Okay. Hello, everyone. Good evening. Thank you so much. I think it's better to start. Uh, so, uh, my name is Diriba. I'm from Ethiopia. I'm the vice chair of the South Africa Research Committee. Today, I will facilitate Kokou's presentation. And so, I think if you have any question, you can drop in the chat box, and you can also raise your hand to ask the questions. Uh, I want to introduce Dr. Kokou, uh, who is a pediatric oncologist at the HO Teaching Hospital, currently serving as a senior lecturer and the head of the Department of Pediatric and the Child Health at the University of Health and Alliance in Ghana. He is an active member of several professional bodies, including SIOP and the American Society of Clinical Oncology. And his work focuses on addressing treatment challenges and enhancing pediatric cancer across Africa. He has been working in different positions, including the department head and being as a senior lecturers, and working
Cuidado.
in different hospitals. He also had different awards, and he contributed significantly to the scientific world. So he had participated in different clinical trials and different researches. So today he is going to present us uh, the challenge of effect of treatment abandonment in Africa. So as I said, you can drop your question in the chat box, as well as you can also raise your hand by using the button, and so that we can entertain you. We encourage you the participant to mute your microphone unless you are to speak for questions. Saying this, Kokou, the stage is yours. You're welcome.
Thank you, Diriba. Thank you for your kind introduction. I'm making this presentation on behalf of the SIOP West Africa Research Group. So we will have a conversation on how the treatment abandonment is strengthening the edifice we are building for childhood cancer diagnosis and care in Africa. So these are the objectives of my presentation. First is to identify the prevalence of treatment abandonment in pediatric cancer care in Africa, centers in Africa. Second, to explore the social, demographic, economic, and cultural factors associated with treatment abandonment. To investigate the healthcare system-related factors contributing to the problem, and to assess the impact the treatment abandonment has on patients' outcome, but also as part of the healthcare system as a whole. And finally, but not the least, to identify some interventions that were carried out aimed at reducing treatment abandonment and how effective they have been. So as an introduction, we are all aware, conversant with treatment abandonment, and the fact that it remains a critical issue for us is being in the past, and then it seems that it has not significantly come down yet. And when we're talking about the treatment abandonment, it's a problem actually of poor countries, and rich countries have managed to reduce that problem to the barest minimum based on the specific interventions they have had. And though some of the interventions have been carried out in poor countries as well, but they have shown some mitigated promises. And still to date, the extent of the problems in poor countries remains inadequately understood and published. So numerous factors still persist that we'll try and brainstorm on today, and hopefully set up the stage for further studies that can bring about a comprehensive and a holistic solution to the problem. So as a definition, various definitions have been used over the years until 2011, when the SIOP, then PODC group, now the Global Health Working Group, wrote a statement paper to define a treatment abandonment that everybody is going to use. So it's either when the patient failed to initiate a curative treatment or discontinue the treatment. All right, it's not continue but discontinue. So the treatment refusal, and it's when the patient do not permit the initiation of the treatment that is deemed to be curable. And discontinuation is when the patient has missed 4 or more consecutive weeks of treatment. So since then, a lot of studies have been done, and then I'm going to show you what has been done in Africa since 2012 to date regarding treatment abandonment in pediatric oncology. So in 2015, Friedrich and Tal did a survey in many countries in the world, including African countries, to find out the magnitude of the problem, and then also identify some of the factors. So first of all, this graph I'm showing here, at the time, they defined the countries based on their income. So I just want you to have a look at Africa and then where we stand. As usual, we still lack a lot of countries presenting their data. So in gray, these are the countries without the data. But as we are all aware, all those countries in gray and the rest in green will be classified as lower or middle income countries. So having this picture in mind, just contrast it with the prevalence of abandonment, or the perceived prevalence of abandonment as stated by the caregivers who were interviewed at the time. As you can see, prevalence of treatment abandonment is a problem of poor countries. And in Africa, we have prevalence that usually, maybe if you exclude the northern part and now the southern part, you have prevalence above 25% of our patients. And then we want to focus on this during the next few minutes of our discussion. So from what we found, combing the literature in Africa, is that still from even still the treatment abandonment of pediatric cancer cases is still high, with an average of 25%, and that there are variability across regions and then the tumor type. So here I want to show you some summarized table of published data on the prevalence of treatment abandonment with studies that encompasses or that involve all tumors altogether. As you can see, so I grouped them in terms of the year of publication from 2013 to recent 2023. So as you can see, the prevalence is still high, but you can see some reduction over the years from 2015 or so. Of course, this is no the data from the same country, all right? But to prove that there's some reduction, I just want you to have a look at Malawi here. So in Malawi, you can see that there's a change there's an improvement in the prevalence or the rate from 2017-18 to 2019-20 to 2020, where the prevalence reduced from 19% to 7%. Sorry for my animation, it did not come well, but the next is to talk about the refusal of treatment. there's a mistake there, but do not take it too seriously. The refusal of treatment here that we presented is the percentage of patients who refuse treatments as over the number of patients who abandon treatment as a whole. And these again have been reported only by few publications. And you can see that it's almost stagnant at 12%, all right? First of all, what we would like to say is that we have a fewer published studies over the years. There seems
Kokou, you are muted.
somebody has muted me. Okay, so I was saying that if you look at this table, you can see that only few countries have reported their abandonment rate. There seemed to be an improvement, but still, the average that was found in the minimum that was found in 2015 survey remains kind of the average these days. So there's a lot we need to do about it. And the refusal of treatment as compared to the total number of abandonment rate is stagnant, even though we saw some improvement in Kenya. Again, this is not an homogeneous publication study. So now let's look at specific cancers. So looking at specific cancers, some fewer studies also have studied abandonment rate in Wilms tumor, non-Hodgkin lymphoma, and acute myeloid leukemia, basically. As you can see, the treatment abandonment rate is high across the tumors, but it's better with Wilms tumor, as we can see with the Wilms tumor, even though there's an improved, as we can see in this slide that I'm going to show now. And this slide, again, is from the data published by Friedrich and al. We saw that based on perceived prevalence and comparing the prevalence in high income countries, in lower income countries, the red represents the low middle income countries, and the gray is high income countries. First of all, it confirms that the treatment abandonment is a problem of poorer countries, one, and that the magnitude differ based on the tumors. It's not the same trend in high-income countries as compared to lower and medium-income countries. Okay. Now, talking about lower and medium-income countries, we will see that the abandonment is higher with the bone sarcomas and AML. First of all, probably because we have limited access to care in those countries. And surprisingly, also the rate is high in retinoblastoma and ALL, where you may think that treatment could be or cure is possible, and probably because of the perception or the likelihood that some patients in the retinoblastoma will have surgery, or in ALL, probably because of side effect or treatment. But in any case, we can understand that advanced presentation could be a reason. And brain tumors also, and then soft tissue sarcoma, as well as low-grade gliomas, have a very high likelihood of abandonment in lower and medium income countries. And as we saw from the previous table, Wilms tumors and Hodgkin lymphoma carries one of the lowest, probably because of the intensity of care and the rest. So when do patients tend to abandon treatment? So from the studies, as a summary, we've seen that most patients will abandon treatment within 3 months of starting chemotherapy or whilst awaiting surgery. Here is a case study based on a survey done in Ethiopia that covers the 4 main cancers, notably the ALL, non-Hodgkin lymphoma, Wilms tumor, and bone sarcoma. So the blue bars represent ALL. And if you follow that, you'll see that, first of all, the baseline abandonment rate is high, about 15%, and it increases sharply during maintenance, which is surprising because you expect that when patients are doing well, they will want to continue treatment, but it's probably the opposite in some cases. Being well also be a risk of abandoning treatment. The same trend is also found in non-Hodgkin lymphoma, which is in, is it pink here? And not surprisingly, we will see that the solid tumors will abandon treatment when they are waiting or post-surgical period. Here, let's have a look at this. When there's no response to treatment or there's relapse, patients tend to abandon treatment. All these things the trend tells us that we need to improve communication. So patients and caregiver need to understand how the treatment is going to go, and then the importance of following treatment through. But again, communication is one way, but we also understand that there are other drivers to how well they are going to follow the treatment that we are going to discuss very soon. So what are those determinants of treatment abandonment? There was some understanding, or this global survey has laid out the main key concept to the drivers to treatment abandonment rate of pediatric cancer cases in every country, both high-income countries and poorer countries. And they centered around the patient, the family, and the cancer center, and also the context. That's the country, national, international context. So from previous studies, they've identified some determinants that are put on the top. And based on their study, newer themes have emerged. So let's look at the previous one. For instance, the patient. The age of the patient could be a determinant. Some studies have reported that older patients tend to abandon treatment. Others have also shown that being a male could be a risk factor for treatment abandonment, but other studies have also shown that rather female, which means that there's no clear finding in that domain. Presence of comorbidities like malnutrition and HIV could also play an important role. Again, here there's no clear-cut finding when we are talking about HIV. Some studies have shown that being HIV positive rather improve adherence to treatment, probably because they are looked after better. But other studies have shown that being HIV negative rather will be the case. So again, that called for a continuous investigation into what really matters to patients and then what really contribute to their adherence to the treatment. Poor prognosis could be a risk factor for treatment abandonment. With regard to the family, believe that cancer is not curable or that alternative medicines are better could increase abandonment. Poor socioeconomic status, of course, as we'll see very soon in many studies, poorer families tend to abandon treatment. But at the end of the day, we want to prove that finances as a whole is not just a matter of the patient, but as a matter of the center or the country. So finances is an important determinant to abandonment, treatment abandonment, and then not just at the patient's level or the family level, but also at the center and the context level as well. And regarding the center, some patients who abandon treatment because of painful treatment or procedures such as surgery and the rest. And a lack of communications could contribute hugely to how well patients are going to follow through the treatment or not. So regarding context, we've proven earlier that being in a poor country increases your likelihood of abandoning treatment. And the emerging themes that they've identified were at the patient level, the vulnerability or treatment-related causes, family dynamics, the cancer centers capacity, and the healthcare finances. These are very important. And we have seen, as we are addressing them one by one, we see that there are newer and emerging teams as well, apart from those that were identified earlier. So this is a graph. It's a bit, it may be cumbersome, but I want you to focus on sub-Saharan Africa. First of all, the point I want to make here is that the teams are the same wherever you are in the world. It's just the magnitude of them or the impact they will have on the likelihood of the patients abandoning treatment that's different. For instance, in poorer countries, you see that low socioeconomic status, low education, or long travel time will play an important role in how well the patients are going to follow through the treatment or not. So what we did is that we look at the recent publications since the SIOP PODC statement paper to find out what are the themes or the factors that led to abandonment in Africa, using the same themes that were published by Friedrich et al. In 2016. We found that the magnitude of low socioeconomic status, alternative medicine travel time is still are still constant, but the newer team that were identified, which were not presented in the previous slide, came in strongly, such as the diagnostic delays, drug unavailability, logistical challenge, and the rest. In my view, even though these may not be reported by many studies, what we did here just the number of studies who reported on those issues. I believe that these are very important issues, probably just that many patients don't talk about it. And interestingly, you also see that lack of amenities for distracting children or poor hospital catering also play an important role. So it means that taking care of or addressing the problem of treatment abandonment in Africa should be a more holistic issue. And not only that, it has to be continuous. So there are different aspects that will affect different teams that will be present in different parts of Africa. But in addressing them, we need to always be on the lookout for newer impact. For instance, you see some places where there's a good health financing present, yet patients are going to abandon treatment, meaning that you need to look for other issues that will really matter to them. Otherwise, they will leave treatment. So it shouldn't be like a one-stop or one-time research or issue that we need to address. It has to be continuous so that we ensure that patients come to care and remain in care. So what are the outcomes of treatment abandonment? As you can guess, treatment abandonment will lead to death. Studies have reported as high as 90% of patients who abandon treatment will die since they have not received enough treatment. Another consequence of treatment abandonment is actually treatment abandonment, meaning that some patients may be encouraged to come back to treatment, but it's as high as half of them are going to go back again. Again, it highlights the importance of communication, but in addition, the fact that we need to find out what matters most to people so that we can address them in a holistic manner. The other very important aspect of treatment abandonment or outcome is loss of investor resources. Here, I just want to present a recent paper on the financial cost of pediatric cancer care in Africa. It was a systematic review. First of all, the first table shows that the cost of caring for cancer patients varies across African regions, probably because of the quality of logistics that are present, the type of cancers that are given curative treatment as well. And now if you come to the second table that shows the specific cancers, you can see that cancer treatment may require as high as almost $90,000 to treat such as is in the case of neuroblastoma. Some cases may not require that much of an investment. Nonetheless, you should look at the percentage of this cost per patient compared to the GDP per capita. As you can see, it's an important component of the GDP per capita, almost 80%, meaning that if patients abandon treatment, all these resources that we invested, training, healthcare professional, the oncologist, the diagnostic tools, and the time spent as social workers, or the accommodation given, transportation, all the other monies that we given, all those things that the treatment that we given, all those things will go to waste. Some countries they have implemented some policies such that one patient who benefit of their from their finances will follow through the treatment. If they don't, then they cannot come back again and access those funds. But in many countries in Africa, and in my experience as well, when patients come back, and we know very well that the prognosis is very poor, sometimes we tend to spend extra money and extra time and money on them, which means that all those things are now going to a total loss. So these are only few impacts I wanted to present to us. So the fact that mortality is high, the fact that patients are going to abandon the treatment again, the fact that we are losing everything that we are putting in place to make sure that the patients, the little resources that we have, that we are putting in place to make sure that the patient are cured. So what are the strategies that can be used to address treatment abandonment in Africa? So I will present you 4 case studies. But before I address them, I just want to bring forth these success stories from tuberculosis programs, and that we can adopt. And we know that many efforts have been made in the area of childhood cancers as well that we can learn from. There are specific success stories from India and the rest. So what this tuberculosis program did is that it just tried to touch on all the different areas that could potentially lead to abandonment, okay? So in a holistic manner. So it talks about the care delivery, the health system, social protection, education, and the psychological teams. By first identifying the threats to adherence, treatment adherence, and then providing solutions. For instance, in the healthcare system, you can have more patient-centered services. We have adequate tracer system. We can social protection, support, food transportations. We know we are doing a little bit of all these things at our various places. So, but you will see that doing one or few ones and not doing others are probably not going to work. So we need to probably do all of them at the same time so that we can get more significant and sustained solutions. So few things have been done in Africa as well that has been successful. The first case I would like to present is that of Malawi, where a comprehensive care package has been introduced. First of all, I would like to say that in Malawi, cancer care was free before the intervention or the introduction of this comprehensive care package. Even then, even though the care had been free, abandonment rate was very high. That's close to 22%. Okay. So, and they decided to, in addition to that, cover the full cost of the transport, ensure there's a systematic counseling on treatment completion. They check the treatment diary daily so that they can track and trace patients more adequately. And when a patient complete treatment, they'll celebrate the patient on the ward. And of course, there will be probably other improvements that will be made over time. And when they did that, they were able to reduce the abandonment rate from 2017 to 2018 period, which was like 19% to 7% for the period of 2019 and 2020. So talking about tracking and tracing, I just want to present this algorithm that was used by Savaleria and Tal. What they did is that, so they check the chemotherapy appointment or appointment consultation every day. And when the patient is absent, then they will phone the contact, they will phone the caregiver on the first day or the second day after the absence. So if the patient shows up, good. If the patient does not show up, then they will contact the local communities and other people that can contact the patient, and they will make the contact a week after the absence. If there's no show, they will make the contact the second week, and they improve on the people they're going to involve in searching for those patients. It's after that they are going to declare that the patient has abandoned treatment if after 4 weeks there's still no show. What this means is that treatment abandonment shouldn't be treated as a retrospective issue, because most of the studies that you see have reported treatment abandonment retrospectively. So if we do more prospective studies, we'll be able to track the patients more effectively and then report on the issues that do not work so that we can change them over time, instead of waiting for a certain period before saying that this is the number of patients who have abandoned the treatment. So second case, the case of Kenya, where the abandonment rate for patients who diagnosed with AML have been reduced drastically just by adopting the PSYOP treatment protocol for AML. So what happened is that along the line, there was an improvement in care when they introduced flow cytometry, so was able to distinguish patients with AML from ALL, and then they were able to counsel patients quickly. Those who go on palliative care will go on palliative care. Those who can have some curative treatment will be now followed through. So those patients, instead of the previous time where they would just go and give a curative treatment, they will start with a prephase that consisted of low-dose etoposide, or there will be a prephase 1 and prephase 2 before they go on to the high DAC. These reduce drastically treatment-related mortality and reduce abandonment. Here again, I want to say that if you look at many studies, abandonment rates is high at centers where treatment-related mortality is high, meaning that if we find ways of improving care, as it is done in this case, where they expanded supportive care, you realize that this will give hope to patients, and possibly the fewer are going to abandon treatment. So this is what they reported. So for the period of 2010-2018, we had 22% abandonment rate. And if you compare to when they've introduced the PODC protocol, and they had an abandonment rate of 3%. Of course, the study periods are not the same. The intervention period is shorter than what was reported previously. So the third case scenario is that of Kenya again, where they introduced, they found that health insurance has an important or significant impact on how the patients, first of all, are going to abandon, the likelihood of abandoning treatment, but not only that, on the survival of the patient. So in the panel A, they presented overall survival, and the panel B, that the event-free survival. So in green, you see, so what happened is that at that time, the percentage of patients with national health insurance was around 40%. So when patient came, a lot of them have been put on national health insurance during their treatment. So they increased that 40%, they almost double that number. So the blue are those who had national health insurance before treatment, and the green are those who were put on treatment. And those who are the yellow here are those who have not had treatment, national health insurance at all. As you can see, with both overall survival and event-free survival, you see that the survival is similar among those who had national health insurance initially or who were put on national health insurance during treatment as compared to those who did not have health insurance at all during treatment, who had a very low survival. And they also had the highest abandonment rate, meaning that, again, financing is an important issue. The last but not the least is a study on lymphoma done in Ivory Coast. And this study had children and both children and adults. So the difference, the only thing they've introduced is the improvement in communication. So patients were randomized into two groups. So one group, they continued as usual. And in the other group, they provided free mobile phone to the caregiver or to the patient if the patient is old enough. And they have weekly communication with those patients by a trained navigation nurse with regard to treatment toxicity. And if there's any issue, those issues were reported to the oncologist. At the end of the intervention, they were able to have the likelihood or the abandonment rate among those patients, even though the abandonment is still very, very high in both groups. So what I was trying to say is that, as you can see, various interventions have been able to have an impact, but the impact is not probably that always significant in many areas. So we need to have all those interventions in a more comprehensive and a holistic manner. Then we are more likely to have a meaningful impact. And before I finish, I want to come back again to this. Usually we think that when we say treatment abandonment, it has everything to do with the patient. But I want to bring back to us that we play a very important role. Our healthcare financing or the quality of care that we can give play an important role. For instance, we know that delays in care increases the likelihood of mortality. And we know very well that healthcare or the health system delays are more important than patient delays, meaning that all the issues or the drivers of the delays are probably the same as those of treatment abandonment. So if we can solve these problems, give hope to people, care to them in a more timely manner with accurate diagnosis, adequate care, good supportive care, more are going to survive, less are going to have treatment-related mortality, and likely that they are not going to abandon treatment. I had a conversation with one oncologist recently who said everything is being done to the patient. So cancer is free, they cover for everything. So they found a way of tracking rigorously the patients and making sure that none of them abandon treatment. And if you look at their data, the survival rate is amazing. So we can do this. In doing so, please let's look at our healthcare system. This is a recent study published by Prof. Hill and Parr that showed that still many countries in Africa are still having challenges with chemotherapy drugs and surgery. Even those who have the chemo, we know how well or how accessible it is. Even if it's available, it does not mean that it's affordable. And we are just talking about chemo drugs, but we are not also talking about the supportive care. So holistic approach is what we believe that is going to help us tackle this problem. So before I finish, I just want to throw in some few research ideas that we can conduct to address the problem. First, we can assess the effectiveness of the various financial support mechanisms in reducing treatment abandonment rate. We are throwing money out. We need to know how well it works, even because we found that in some countries, financing patients alone may not be enough. It does not always reduce abandonment. and evaluate the impact of healthcare system improvement on treatment adherence and patient outcome. Third, we can examine the effectiveness of psychological support programs, including the counseling that we do and a support group in improving the treatment adherence. We can conduct longitudinal studies to track treatment adherence, abandonment rate, and long-term outcome in our patients. We can develop and test community-based interventions since some of the drivers of abandonment are the community members who will tell patients that the treatment does not work or there's no hope and all that, or even outright deter them from coming to the hospital. The last but not the least, we can assess the impact of health education programs aimed at patient, family, and community on treatment adherence. It's similar to what I spoke about earlier, but here is more of an education. So to conclude, I want to say that I've shown that there's a variability of treatment abandonment rates in Africa. Many countries still do not report the abandonment rates, making comparison very difficult. And the causes are multifaceted and may differ from one center to the other, okay? So whilst financial constraints are major issues, not only at the patient or the family level, but also at the center and the country level, there are emerging factors each time you look into the problem. So which means that we need region-specific interventions. We need continuous assessment of the problem so that we can address it adequately. There have been some effective interventions, such as the comprehensive care packages, advocacy, and these are promising and needs to be scaled up. So, as I said, improving the healthcare system should have the most significant impact. Once patients are surviving, abandonment rate should reduce. At the same time, I know people will say that, okay, abandonment rate contribute to mortality, but if treatment-related mortality is reducing, maybe, just maybe, patients are going to abandon the care less. So I would like to thank you for your attention. Special thanks to Prof. Boubacar Togo and to the Southwest Africa Research Group. Thanks to Jacques and Diriba here present. Now I'm going to pause for any question, comment. Thank you.
Thank you, Dr. Kokou, for your nice presentation. It's very insightful, comprehensive presentation. So now is the stage for time for question. If you have any question, you can raise your hand or anyone can jump in to just ask questions or also can add something on what Dr. Kokou has been said. So the time is for the participants. I don't see any hand so far. Any question? Okay, thank you so much, Dr. Kokou. So saying this, I think Dr. Kokou has came up with a very interesting to-do list in the future. As you have seen on the last slides, he has proposed what we can do to reduce this treatment abandonment and its impact on the treatment outcome of children in Africa. And that obviously treatment abandonment is it is cross-cutting and it's a problem of everyone. Yeah, this one. So Kokou and the West Africa team is not going to do this alone. So this is like very, very important areas. One thing, okay, the team here or the participant here can add something or propose additional to do ideas. And if you are interested to participate in one of these areas or in the treatment abandonment working group, as you can reach out to Dr. Kokou. Dr. Kokou, you can just post us your email on this chat box so that everyone can, everyone who want to join the treatment abandonment working group can join the team. And I think, yeah, after that we can talk how to proceed together. And maybe question for Kokou. Have you like prioritized to do which one are we going to do first and then the others, or how did you plan to continue this like about six research areas? Did you identify the priority areas, or how did you plan to continue with this so that the team may understand more what's going to be done? Or is there anything undergoing, or what are the initiatives, active initiative, or are this only the proposed and just it is at the conceptual level?
Yes, thank you, Diriba. So this is at the conceptual level. So when we took up the task to discuss treatment abandonment, the team has decided that we should come the published literature first to find out what we have. Then we can proceed from there. And if you, as you ask me, I will probably first the 4 points when we
you are the night of the district.
Sorry, there's some interference.
Just check
Okay,
it.
so I'll just continue. I will prioritize the fourth topic, the longitudinal studies to track treatment adherence, abandonment rates, and long-term outcomes, because as you do that, you realize that you put in every other aspect, the financial, the community-based interventions and all that can be put in. So at the continent level, so we can see how we can collaborate together to achieve this, and so that we can give result in real time manner instead of the retrospective way that usually happens.
Thank you, Kokou. I think that sounds great. I mean, just tracking the
Reba, there are two hands. The first one is Doreen, and the second one is then Train Israel.
Okay, thank you. Jack, I didn't see it. Okay, Doreen, you can continue. Dr. Doreen. Yes, Doreen Karim. Trin, you can continue. Maybe she may have some technical problem.
Thank you, Diriba. And congratulations, Dr. Kokou, with this wonderful, comprehensive presentation. Really very interesting. I've worked a lot in Malawi, so happy to have contributed to the presentation in that sense. Actually, my question was the same as Diriba's. What would you prioritize out of your strong conceptual list of next steps? So I'm a bit lost for a question now, but happy to support wherever I can, and really well done. Thank you so much.
Thank you.
Kokou, what I just want to add here is that while you and I were working on this, what came to me is that there's a strong component of patient empowerment that needs to happen. I mean, working in Belgium, we don't have different problems with patients versus African countries, because we have a lot of refugees from different countries, and in a single day we have to function in at least 6 different languages, and we have a lot of translators. So we do have the resources to have a lot of translators to speak to patients, but it comes through time and time again that continuously and repeatedly informing the parents and the patients what's going on, why things are happening, how solving problems with them, becomes really important. So I don't know how, if you also saw that communication not only to the patient, but the team as well is really important. And then I just want to extrapolate that in Africa, I think that we mustn't forget about communication to the governments, because I'm not sure that the whole political realm or health systems are on board with pediatric oncology. Did you find anything similar in your thoughts?
Yes, Jacques, you are totally right about the communication, and it came across in many of the studies. And as we can see, when we have good health financing at the state level, you see that adherence is going to improve. Unfortunately, as you rightly nailed it, a lot of African countries are not, or the institute or the government are probably not too well aware of the problem, or do not provide the adequate support. That's why we are where we are. So that's why I was saying that the financing is a big problem first. So if you have good healthcare system, we should be able to reduce the adherence. So it's communication at every level, at the institutional, the political level, and institutional level, at the caregivers, and also at the patient's level, the community levels. If we can do all that, and we'll realize that the patients will be empowered. They know that they are being cared for, adequately supported, and that gives them hope. We need to give them hope so that they can continue the treatment and get the cure that is needed.
Deriba, can you see the feed? Otherwise, Doreen has just
Yes, there are questions.
Go for it.
Yeah. So there is one question before Doreen from Chabichuk. I'm sorry for the naming. What about the treatment abandonment according to the type of treatment, especially for bone surgical treatment, for example, especially amputation? And what about association of complementary treatment that could impact the chemotherapy toxicity? This is one of the questions. Maybe you can respond to this. You can also see the chat box, Kokou.
Okay.
And Doreen also another question, then you can respond to that as well.
That's fine. Thank you, Shapchup. So there are no specific study that reported on those, apart from the view of the healthcare workers, the oncologists in Ethiopia. The same thing was, we are talking about Africa. So we've seen that in the abandonment rate is higher in bone sarcomas and also other tumors, as reported by the oncologists themselves. But those studies actually reported on those specific cancers to see the likelihood that those patients abandoning treatment. Again, that highlights the fact that we need more studies that will document the problem first, and then we can address it. Again, the alternative treatments are those reported, the preference for alternative treatment are those reported by the patients and caregivers. And so those are what we saw in the studies, but no studies are reported that the impact they have had on the patient's outcome. What we know is most of the patients who abandon treatment are going to die. Probably they sought alternative treatment, but they've died anyway. Again, conducting a more longitudinal prospective study will address those questions. This is a very important question. Thank you. Diriba, should I go to the second one?
Yeah, you can go to the second question.
Okay.
From Doreen.
So the second question by Doreen is, any experience or data or healthcare workers' attitude and organization or services or centers influence, if they influence the treatment abandonment. Again, some caregivers are reported inadequate information that the caregivers have given them that that kind of made them abandon treatment. Maybe they are not telling the whole story, because in some recent studies, it's been shown that now people started complaining about the quality of care they receive, even things that we would not consider important, like food and even a play area for their children. So maybe they are, since we are the one asking them questions, they may not be able to tell us the whole story. But again, if it becomes a program at many places, we'll see that people will talk more, and it will help us improve the care that we give them. Our attitude towards them as well will improve, so that they can adhere treatment better. That's what came to my mind.
Okay, thank you, Kokou. I think there is one the message. I'm very sad to see that only so Hadu is present as the only Francophone oncologist. Maybe is this because of the reach of our email or the WhatsApp? Maybe I think we have to see this as well. This very important point. Is it due to the reach of our WhatsApp group, or maybe the initiative of participation? Jax, can you reflect on this?
Well, Deriba, we report, well, we advertise this on the WhatsApp group. Emails go out. It's also on social media. Professor Giel is very, she puts it on Twitter and on all these things. So I'm sure that we can do much better if we have more emails as well. But I know that the emails that goes out to about 500 different people, of which a lot of them are Francophone countries. So maybe it's a language barrier, I'm not sure.
Okay. So is there a way to have a translation? I can see on different Zoom meetings, there is a translation service. Is there a way to do that?
I think it's made due to the language barrier.
Yeah. Does
Because
it something
many of the Francophone oncologists, they cannot speak and don't understand very well the speech.
You are right. You are right.
That is the reason.
I think this is very important point. We need to address this. Maybe we can talk, especially if there is a possibility of like having a translation. Just there is a technology, or I mean, Zoom can do that. I'm not sure whether it costs additional cost or it's only setting. We have to check that.
I do know that Zoom, I'm not just sure if Zoom has it, but I know that Teams and so forth has an automatic translator. When somebody is speaking, it can give you the translation in another language. So we'll have a look at that, Deriba, when you and myself and Riam meet.
Okay. Okay. Thank you, Dr. Babukar, for bringing this very important point to our attention. Thank you so much. I think...
but there's one more question.
Okay.
From Frida.
Okay, Daniel. Yeah.
Yeah, so she's asking if there's any study on drug resistance, the resistance associated with treatment abandonment in those who abandoned and came later. I've not seen any study like that, but there were studies on a high abandonment rate in patients who have had refractory or relapse disease. I don't know if it has anything to do with drug resistance. There are some patients who also have abandoned treatment because of drug unavailability, but no specifically on drug resistance. Thank you.
Thank you. There is also a question about if there is a WhatsApp group about treatment abandonment. Okay, you can respond, Kokou, that as well. To my knowledge, there is no continent level WhatsApp group, but Kokou can clarify that.
We have a WhatsApp group for West Africa, West Africa, but there's no WhatsApp group specifically for treatment abandonment. So as I said earlier, it's one of the themes that we decided to embark on. So this is just the, what do I call it? The baseline study. And from here, that we can discuss the way forward. Having a WhatsApp group, if that will be helpful, then we can have that and I take it forward.
Thank you. I think that's the next step.
Deriba, just as we've made working groups, some of other topics like the supportive care and so forth, the SIAP research group committee will also start a working group around abandonment. So, Boubacar, c'est aussi pour les francophones collègues, donc pour parler avec votre collègue pour les groupes d'abandonnement. OK?
OK. OK, mais bon, je ne suis pas très content parce que nous avons eu des réunions et aujourd'hui, personne n'est là. Et donc, ça, c'est pas intéressant. Kokou, je te félicite, c'est très bien. Oui.
Oui, et évidemment, pour vous, nous pouvons traduire les dias en français pour vous.
Ouais, OK.
Oui, professeur, je peux traduire en
Merci.
français. Peut-être que c'est aussi de ma faute.
Oui.
À Africa, il y a beaucoup de choses qui se sont passées.
Ouais, bon,
Donc,
peut-être
on n'a
qu'on
pas
aurait
pu
dû
suivre.
échanger sur WhatsApp, informer. Peut-être que c'est un peu dur, ça aussi, on n'a pas informé.
Oui.
Non, et pourtant, ça a été dit. Hein.
Voilà.
Bon,
comme on a programmé, on a planifié,
oui.
donc on aura l'étude qui sera faite. Donc,
oui.
Oui.
OK. En tout cas,
Professeur Bober, pouvez-vous collecter les emails ou courriels électroniques de les collègues
oui.
francophones, s'il vous plaît?
OK.
Merci.
Merci. OK. En tout cas, very good presentation. Thank you, Kokou, for West African group. Thank you, everyone.
Appreciate it. Thank you.
Thank you. So,
Deriba, up to you.
Respond one question. There is one question, the last question, and we'll conclude. We are about 5 minutes over our time.
Okay.
Thank you.
Okay. I think the question from Daniel.
Yeah.
How huge is the role of seeking alternate traditional herbal medicine by caregivers in contributing to treatment abandonment? From the graph, you will see that it's a problem everywhere in the world, but it's more in the poor countries. So yes, so it's an important problem. So a lot of people will go to herbal preparations, herbalists or traditional so-called doctors after probably that we don't give them hope. So it's very high in many of the studies that we've combed here.
Thank you. Lulu also added one question. Last question. What is the role of distance of health facility on treatment abandonment?
Yes, so delay, the long distance has been found by the studies by Friedrich and Tal. And then also we've shown that in the studies that were published in Africa as well. So I just want to show the graph again. Sorry, they are so tiny. But as you can see, 4 studies out of the 13 reported on long travel time contributing to treatment abandonment. So it's an important problem.
Thank you. Thanks so much, Kokou and the team. It is a very interesting discussion with very valuable points. So, as I said, maybe as a reminder, let you reach to Dr. Kokou for those who are interested to join this working group. Then the next will be creating the WhatsApp group for treatment abandonment of in Africa. Thanks so much.
Thank you.
We'll conclude our session here. Thank you.
Thank you.
Bye.